Hello, I'm going to speak about heart failure with a preserved ejection fraction, an entity formerly known as diastolic heart failure, and I'm going to try to speak if it is a myth or reality, as exemplified by the Emperor Preserved trial. The Emperor trial was a trial that was published in the New England in October 14th, 2021. In this trial, they picked up almost 6,000 patients with heart failure clinically on a class 2 to 4 and an ejection fraction above 40%. And they were divided and randomized to receive either empagliflozin 10 milligrams once daily or placebo in addition to usual therapy. They were followed for a median of 26.2 months over 2 years, and the primary outcome was a composite of cardiovascular death or hospitalization for heart failure. And after over 2 years, this primary outcome happened in 17.1% of placebo patients and 13.8% of empagliflozin patients, an absolute reduction of 3.3% or a relative reduction of 21%. As in the table in the higher part of this slide, you can see that the hospitalization for heart failure was reduced from 11.8% to 8.6%, an absolute reduction of 3.2% and a relative reduction of 29%. And cardiovascular death had a 0.9% reduction that was statistically non-significant. So the primary outcome was reduced because of the reduction in hospitalization for heart failure. And if I was going to speak only about this trial, this would be the end of my presentation. The problem is that the devil is in the details, and there are a lot of details on this study and on heart failure with a preserved ejection fraction that we must talk about. And first we must speak a little bit about history, because this all started 400 years ago. When William Harvey described the circulation and stated that the intrinsic motion of the heart is not the diastole but the systole. Neither is it in the diastole that the heart grows firm and tense, but in the systole, for then only is it moved and made vigorous. And so, for 350 years, we only spoke, thought, and studied the systole. Until in the 50s and 60s of last century, 3 entities were described in which there was heart dysfunction at the expenses of the diastole. The dysfunction was in the diastole and not in the systole. And so diastolic dysfunction was found. And we started studying diastolic dysfunction in the 70s and 80s. Many studies were published, and in 1995, Vassan and collaborators published a review that found 31 studies published between 1972 and 1995 on diastolic dysfunction. And in 1998, 2007, 2019, 3 European guidelines specifically on diastolic heart failure or heart failure with a preserved ejection fraction were published. And in 2012, 2016, and 2021, 3 European guidelines on globally heart failure, but with a specific chapter on heart failure with a preserved ejection fraction were also published. And the 3 documents published specifically on this entity, 1998, 2007, and 2019, had interestingly an evolution on their titles. The first one, from 1998, said how to diagnose diastolic heart failure. The second, from 2007, said how to diagnose diastolic heart failure, but then said a consensus statement on the diagnosis of heart failure with a normal left ventricular ejection fraction. And the last one, 2019, said how to diagnose heart failure with a preserved ejection fraction. There was an evolution in the name applied to this entity. The first one, 1998, said that the diagnosis of diastolic heart failure required three things: signs or symptoms of heart failure, a normal or mildly abnormal left ventricular systolic function, and evidence of abnormal diastolic function. 2007, same thing. First, signs or symptoms of heart failure. Second, normal or mildly abnormal systolic left ventricular function. Third, evidence of diastolic dysfunction. 2019, a little bit different. They had an algorithm, a diagnostic algorithm with 4 steps, and they also showed it in like a tree. And the first step was to find a breathless patient and to rule out other causes other than heart failure. And then if the first assessment was compatible with heart failure with a preserved ejection fraction, we should do a more thorough echocardiogram. And with that echocardiogram and the BNP values, they would have a score with major and minor criteria. And if the points were equal or above 5 points, you could make the diagnosis of heart failure with a preserved ejection fraction. If it was under 2, this was not a diagnosis. And if it was between 2 or 4, you would have to do more tests, either non-invasive or invasive tests. So all these documents spoke about symptoms and signs of heart failure, an ejection fraction above a certain level, and the evidence of diastolic dysfunction. But again, the devil is in the details of each one of these numbers. First one, symptoms and signs. Everyone says heart failure is a clinical syndrome. Okay, but what's included in this syndrome? And secondly, what's the fiability? False positives, false negatives, sensitivity, specificity of this syndrome for the diagnosis of heart failure. The articles from 98 and 2007 speak about what signs and symptoms belong in this syndrome, and they speak about exertional dyspnea, orthopnea, gallop sounds, and lung crepitations and pulmonary edema. And in 2007, they also speak about ankle swelling and hepatomegaly and fatigue. The heart failure guidelines of 2012 speak of breathlessness, ankle swelling, and fatigue, and certain signs like an elevated jugular venous pressure, pulmonary crackles, and a displaced apex beat. The 2016 guidelines say almost the same, and the 2021 guidelines speak about breathlessness, ankle swelling, and fatigue, and the same signs. So it's easy to say what symptoms and signs belong to the clinical syndrome of heart failure. But what is the fiability of this syndrome? And I found out an article of 1970 in which the authors say that there are no specific signs or symptoms that always indicate the presence of congestive heart failure, because diseases of other organs may be confused with heart disease. They also say something very interesting and wise. They say that it is folly to diagnose heart failure when there is no heart disease. It is folly to diagnose heart failure without heart disease. We will come back to this statement. And the 2007 and 2019 guidelines say that breathlessness especially difficult to interpret in elderly and the obese, who represent a large proportion of the heart failure with a normal ejection fraction population, and that breathlessness on exertion is highly sensitive but only moderately specific for heart failure, and that 50% of people that show breathlessness on exertion will not have heart failure and will have other diagnoses. 50%. That's why on their algorithm, when they begin with the breathless patient, the first thing to do is to rule out other cardiac or non-cardiac causes for the breathlessness. The 2012 guidelines of heart failure say that many of the symptoms of heart failure are non-discriminating and therefore of limited diagnostic value, and sodium and water retention may resolve with diuretic therapy and be less sensitive. And they also say that the diagnosis of heart failure with a preserved ejection fraction is more difficult than the diagnosis of heart failure with a reduced ejection fraction because it is largely one of exclusion. First, we must exclude, rule out all potential non-cardiac causes for the patient's symptoms. They also say that many of the symptoms are non-specific, and they said before that peripheral edema could resolve with diuretics and be non-sensitive for heart failure, but it can also be non-specific because it can have other causes as well. So they say that symptoms and signs, again, may be particularly difficult to identify and interpret in obese, elderly, and patients with chronic lung disease. The 2016 guidelines say almost the same. Symptoms are non-specific. They do not help to discriminate between heart failure and other problems. Signs may be more specific but are harder to detect. And they are especially difficult to identify and interpret in the obese, elderly, and patients with chronic lung disease. 2021 guidelines say the same. Other people with anemia, pulmonary, renal, thyroid, or hepatic disease may have symptoms and signs very similar to those of heart failure. So symptoms and signs lack sufficient accuracy to be used alone to make the diagnosis. A specific report on the differential diagnosis of diastolic heart failure says that it depends on the presentation. If it's an acute presentation on the emergency department or a chronic presentation on the outpatient clinic. On the outpatient clinic, we must rule out obesity and physical deconditioning. On the emergency department, we must think about other heart diseases other than heart failure that can be responsible for the patient's picture, and they speak a lot about respiratory diseases because they say there is an overlap between pulmonary hypertension, chronic obstructive pulmonary disease, and heart failure with a preserved ejection fraction. And chronic obstructive pulmonary disease and other chronic lung diseases not only are difficult to differentiate from heart failure with a preserved ejection fraction, but they are also very prevalent in these patients. So how can you separate them? So we spoke about the clinical syndrome, signs and symptoms, and I showed you that signs and symptoms of heart failure are very poor to identify correctly patients with or without heart failure. The second part is an ejection fraction above a certain level, and I want to answer to these questions. What is a normal ejection fraction? What is a reduced one? What is a preserved ejection fraction? And why do these names and thresholds change? First, I must show you this article from 2005. It's very interesting because the European and American societies societies of echocardiography, they joined hands and they made an article on chamber quantification by ultrasound, and they defined that a normal ejection fraction, the same values for men and women, is one that is equal or above 55%. Normal ejection fraction, 55%. Slightly, mildly abnormal is 45 to 55%. Moderately abnormal is 30 to 45%. And severely abnormal is under 30%. And these values are the most recommended and best validated. The three articles specifically on this subject from 98, 2007 and 2019, the 98 article puts a threshold on 45% and the other two on 50%. A preserved ejection fraction needed to diagnose diastolic or a heart failure with a preserved ejection fraction must be above 50%. The 2012 guidelines also say the same, but they start explaining why these thresholds were defined. And they say that the major trials in heart failure enrolled patients and the reduced ejection fraction, enrolled patients with an ejection fraction under 35%. And only in these patients have effective therapies been demonstrated. In 2016, they say that only in patients with heart failure with a reduced ejection fraction that they defined as under 40% have therapies been shown to reduce both morbidity and mortality. And that is why they divided heart failure patients in patients with an ejection fraction under 40%, they called it reduced. Above 50%, they called it normal or preserved. And they called the patients between 40 and 50% as mid-range patients. In 2021, they again explained that the rationale behind dividing patients according to their ejection fraction relates to the treatment trials that only demonstrate improved outcomes in patients with an ejection fraction under 40%. And in 2021, this year, they said, we have decided, it's incredible how they state this, we have decided on the following classification. This is not science. This is some people that went together, looked at stuff, and decided on certain thresholds, that a reduced ejection fraction is under 40%, a preserved is above 50%, and the guys that have an ejection fraction between 40 and 50% that they are not mid-range anymore, they are now called a mildly reduced. Remember the article from 2005. The patients that have an ejection fraction above 40% include ejection fraction that are severely abnormal and that are moderately abnormal. The patients above 50% include patients with a normal ejection fraction and some patients between 50 and 55 that have a mildly reduced ejection fraction. And the patients between 40 and 50% are a mix of patients with a mildly reduced and moderately reduced ejection fraction if we are to apply the definition of chamber quantification of the American and European echocardiography societies. So answering my questions, what is a normal ejection fraction? Is one above 55%, remember that? A reduced one, it has been defined as one under 40%, while a preserved one is one above 50%. And the ones who have an ejection fraction between 40 or 50%, well, their name changes over time. And why do these names and thresholds change? On my opinion, and on what is written on the guidelines, is to isolate patients that will have better improvement in outcomes in randomized clinical trials. So the advantage is for the companies that manufacture medications, because they will have trials that will have very good results on relative reduction in outcomes. If they included all patients under 55% of ejection fraction, all patients with an abnormal ejection fraction, the reduction in outcomes would be much less impressive. And that is why we want to isolate patients with an ejection fraction under 40%. What about diastolic dysfunction? How have we defined it over time? Well, let me show this article from the New England from 2004. In this article, the authors said that the criteria for definite diastolic heart failure are the presence of a normal ejection fraction. Here they said above 50%, okay. Within 3 days after an episode of heart failure, okay, signs and symptoms, and objective evidence of diastolic dysfunction, meaning an abnormal left ventricular relaxation, feeling, or distensibility as measured during cardiac catheterization. They meant you had to have an invasive test to definitely define diastolic heart failure. The 98 article has a lot, it's not very practical to do so, so the 98 article has a lot of echocardiography values and indexes that are needed to define diastolic dysfunction. I would challenge you to remember reports, also echocardiography reports of your patients that would have these information in it. It's very rare. And the 2007 article, when defining diastolic dysfunction, had on the left invasive hemodynamic measurements, and on the right they had a very important measurement, that is the the Doppler E and the flux E. With the E and E of above 15, you can define diastolic dysfunction. When it is between 8 and 15, you have to have other information to define diastolic dysfunction. The 2019 article said almost the same thing. You had to see the tissue Doppler E to see if the relationship between the two E's is above 15 or is it between 8 and 15. One is a major criteria, the other one is a minor criteria, and you also need indexes of left atrial enlargement and of left ventricle hypertrophy, and also BNP values. And the guidelines of 2012 say that no single echocardiography parameter is sufficient accurate to mean and make a diagnosis of left ventricular diastolic dysfunction. You have to have several indexes. You have to have left ventricular hypertrophy, left atrial dilatation, the E ratio above 15, and in 2016 they say the same thing. You have to have structural changes like an enlarged left atria or an hypertrophied left ventricle walls, or an EE above 13. Here they put the threshold on 13, or other indexes like the tricuspid regurgitation velocity above 2.8 meters per second. In the 2021 guidelines, it's more interesting. They also show several indexes, but they speak about the sensitivity and specificity of each of them, which is very useful because it shows us again why no single diastolic dysfunction echocardiography parameter is enough. You have to have several. So it is difficult to find non-invasive objective evidence of diastolic dysfunction. Nevertheless, it is important to do so and not to rely on only one parameter. You have to have several echocardiographic parameters that show the presence of diastolic dysfunction to support your diagnosis of diastolic heart failure or heart failure with a preserved ejection fraction. Now, I would like to speak to you about what's in a name. What happens when we change from the name diastolic heart failure to the name heart failure with a preserved ejection fraction? What happened? What were the causes for this change, and what were the consequences? What were the causes? I told you about the causes of the several classes of ejection fraction, but now I'm speaking the causes for this change in name. And the 2007 article says it very clearly. They say diastolic heart failure is also referred to as heart failure with a normal left ventricular ejection fraction to indicate that it could be a precursor of heart failure with a reduced ejection fraction. This is the argument. They say that diastolic dysfunction exists not only in patients with diastolic heart failure, but patients with systolic heart failure also have evidence that they have systolic dysfunction and diastolic dysfunction as well. And so the distinction between diastolic and systolic heart failure, they say, is challenged. And so some people think that there are not two kinds of heart failure. Heart failure is only one syndrome. And so, because of heart failure being one syndrome, we should not have different names, diastolic heart failure, systolic heart failure. We should have heart failure with a preserved ejection fraction and heart failure with a reduced ejection fraction to show, because it is postulated that there is an evolution from one to the other. And these are a table that shows arguments for and against these two ideas, heart failure as a single syndrome and heart failure with a normal ejection fraction preceding heart failure with a reduced ejection fraction, and the other idea that heart failure are two different syndromes, two different diseases. They say on 2007 that they will use these new terms to replace diastolic heart failure and systolic heart failure, but it does not resolve this issue if heart failure is one syndrome or two syndromes. And this issue is far from resolved. In 2014, in this article, Heart Failure with a Preserved Ejection Fraction, a Clinical Dilemma, these authors still ask the question, is heart failure just one syndrome or two diseases? Is heart failure, a preserved ejection fraction, just a transitory stage in heart failure, or is it a distinct disease? And they think it is a distinct disease. If it is a distinct disease, the argument to change the name from diastolic heart failure to heart failure with a preserved ejection fraction falls down. And again, there's another problem. How can heart failure with a preserved ejection fraction be a precursor of heart failure with a reduced ejection fraction if its patients are older than the other patients? Only if you could travel in space-time could this be true. So the two reasons to change the name, it makes no sense, because heart failure with a preserved ejection fraction makes no sense that it is a precursor that will evolve to heart failure with a reduced ejection fraction. So the causes for the change in name are these, and you can see that these arguments make no sense anymore. What are the consequences of changing the name from diastolic heart failure to heart failure with a preserved ejection fraction? Well, the consequences are these, that most guidelines now, as this 2019 article says on Lancet, agree that the minimum requirements for the diagnosis of heart failure with a preserved ejection fraction are signs and symptoms of heart failure, and we have seen what they are worth or not worth, and the relatively preserved ejection fraction, and here they say when that is above 40%, and that makes no sense because the 40% threshold was used just to make better results for clinical trials. And so what I say is when we change the name, we change our focus. And when we speak about diastolic heart failure, we are focused on finding evidence of diastolic dysfunction, as the guidelines say we should. And when we speak about heart failure with a preserved ejection fraction, our focus changed to finding an ejection fraction above a certain threshold. And in spite of what the guidelines say, we don't comply with the guidelines anymore. In clinical practice, you just have signs and symptoms of heart failure and an ejection fraction above a certain level, and that guy has heart failure with a preserved ejection fraction. And you don't look for diastolic dysfunction no more. So in spite of what Shakespeare said, that a name is not important and a rose will smell the same even if you change its name, here it's not like Shakespeare said. When you change the name of heart failure, you changed the meaning of what you are thinking about. So where are we at? Well, in 2014, these authors in the European Heart Journal asked, does the syndrome of heart failure with a preserved ejection fraction even exist? Or does it simply represent a collection of comorbidities rather than a pathophysiologically distinct entity? In 2019, in Lancet, these ones said, the high prevalence of comorbidities with heart failure with a preserved ejection fraction has contributed to the notion that this condition might not exist as an independent entity, but simply be a collection of comorbidities. And again, what happens? Since no therapy has been shown to improve outcomes in patients who have heart failure with a preserved ejection fraction, and the therapy for these patients is not a specific therapy for heart failure, but it's only the therapy of their comorbidities. If they have hypertension, you treat it. If they've had coronary disease, you treat it. If they have obesity, they must lose weight. If they have kidney disease, if they have lung disease, you must treat those diseases. You must treat the comorbidities of these patients, and you have nothing to give them for the supposed heart failure they have. And so this is a very big argument to say that heart failure with a preserved ejection fraction does not exist as an entity, and it's just a collection of comorbidities, and that's why you don't have a specific treatment for it. And now you understand why when the EMPEROR trial came out and said we have found a therapy that is specific and works for patients with heart failure with a preserved ejection fraction, and everyone was very happy. And some people said, well, we have won against a formidable foe. And Eugene Braunwald, the over 90 years old Eugene Braunwald, said heart failure with a preserved ejection fraction, a stepchild no more. Everyone was very happy. But now let's see the devil in the details of the EMPEROR trial. Let's see the inclusion criteria. And look, to include patients here, they must have chronic heart failure diagnosed for at least 3 months before visit 1. And what do they have to have chronic heart failure diagnosed? Well, they either must have a left atrial enlargement or left ventricular hypertrophy, one or the other. And we have seen that this is not enough to find evidence of diastolic dysfunction. But they might even not have that. If they had an hospitalization for heart failure in the 12 months before visit 1, that would be enough to be included in the trial. And I think we all know of patients that are hospitalized and they are discharged with a diagnosis of hospitalization for heart failure, and lots of times they don't have heart failure. And so these are very easygoing inclusion criteria for this study. But better than that, you remember that all patients in the EMPEROR trial must have an ejection fraction above 40%. And they try to have 1/3 of patients with an ejection fraction between 40 and 50%, 1/3 between 50 and 60%, and 1/3 above 60%. And if you remember the thresholds of the ejection fraction of 2005, American and European, this means that all the patients with an ejection fraction above 60% had a normal ejection fraction. The patients between 50 and 60% had some a normal ejection fraction between 55 and 60, and some a slightly reduced ejection fraction between 50 and 55. And the patients between 40 and 50 include patients with a mildly reduced ejection fraction between 45 and 50, and moderately reduced ejection fraction between 40 and 45. And you also see that only the patients with an ejection fraction above 50% would eventually be accordingly to the 2019 guidelines of this entity, as I showed you. And how did the three subgroups of patients behave on the primary outcome of the trial? And here is how they behaved. Patients with an ejection fraction between 40 and 50%, empagliflozin was better than placebo, and you can see that they don't touch the vertical line, meaning that this is statistically significant. The second subgroup, between 50 and 60%, empagliflozin is better than placebo, but the confidence interval touches the vertical line, which means that the statistical significance is really slight. And the patients with an ejection fraction above 60%, empagliflozin is better than placebo, but it has no statistical significance. So the statistical significance of this trial is moved by the patients with an ejection fraction between 40 and 50%. This is not a preserved ejection fraction. So after speaking with you about all these things, let's speak about conclusions, about their conclusions and mine conclusions. I'm sorry, it's not mine's, it's mine. What conclusions? Well, the article says that it's very clear. This is what everyone will say, what the industry will speak to you. Well, empagliflozin lowers the hospitalization for heart failure. It lowers that risk 29%. 29% it lowers the risk of hospitalization for heart failure in patients with heart failure and the preserved ejection fraction. And what are my conclusions? Well, to speak about that, I must first speak of two types of patients. You must imagine a female 75 years old patient that enters your emergency room in acute pulmonary edema. The patient is severely hypertensive and has an atrial fibrillation with a heart rate of around 145 per minute. The X-ray is typical of acute pulmonary edema, and the transthoracic echo shows left ventricle hypertrophy, an enlarged left atria, and an ejection fraction of about 55%. We make a cardioversion to sinus rhythm, and the patient is beating 70 per minute, and we control blood pressure with several medications, and suddenly everything disappears. The patient is okay, the symptoms go away, the signs go away, and the X-ray turns to normal. And I have no problem saying that this patient has probably diastolic heart failure. Another patient, also a woman, 75 years old, she's obese. She has a chronic type 2 respiratory failure, and she has home oxygen therapy chronically, and she has non-invasive ventilation during the night. She's also always breathless, and she sleeps seated. She cannot lower her head. She has chronic lower limb edema, and her X-ray has big cardiomegaly. The transthoracic echo shows mild pulmonary arterial hypertension. She does not have left ventricle hypertrophy, and she has an ejection fraction with 45% of 45%, and she has an enlarged also left atria, And I can ask you, what is the diagnosis of this patient? Does she have heart failure? Or doesn't she have heart failure? And she has heart failure. Is it a preserved or reduced ejection fraction heart failure? Would she be included in the Emperor's trial or not? And so my conclusion is that heart failure is a preserved ejection fraction, is a mixed up confusion, like the music by Bob Dylan. It's mixed up confusion. And empagliflozin lowers the risk of hospitalization for heart failure 1.5% per year, because we must not speak about relative reduction of risks. We must speak about absolute reductions of risk and per unit of time. It's stupid to say 29% lower risk when we are not speaking on for how long and when we don't know what the absolute reduction is, because the absolute reduction per year that empagliflozin gave to these patients was 1.5% per year. You must treat 200 patients with empagliflozin to avoid 3 hospitalizations for heart failure. And these were mostly on patients with an ejection fraction between 40 to 50%. And don't forget, an ejection fraction between 40 to 50 is not the same as 50 to 60 and is not the same as above 60. Another conclusion is that symptoms and signs of heart failure and an ejection fraction above a certain level is not enough to diagnose heart failure with a preserved ejection fraction. Remember and use the 2019 heart failure algorithm. A change in name of this entity changed our focus, and no one remembers about looking for diastolic dysfunction evidence. They don't look about it. We should call it diastolic heart failure, because this really exists, but we must always demand for evidence of diastolic dysfunction, or else we'll only end up with what this article said in 2001. In practice, the diagnosis of diastolic heart failure is based on the findings of typical symptoms and signs of heart failure that are worth very little in a patient who is shown to have a normal left ventricular ejection fraction and no valvular abnormalities on echo. Do not think like that, because it is folly to diagnose heart failure when there is no heart disease, and we must think or still think if heart failure, even with a preserved ejection fraction, even exists. If that patient in front of us is just a collection of comorbidities that we must treat and correct, or is heart failure with a preserved ejection fraction just another myth? Thank you for watching.